All right, thank you for joining me today for this event on the medical review findings in the IVIG reviews, or immunoglobulin intravenous reviews. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. I'm also joined by other members of Provider Outreach and Education, as well as medical review, who are going to be helping with the chat as well as the Q&A at the end of today's call. A few housekeeping items before we get started. So as I mentioned briefly before, we have a training center on our webpage on WPSGHA.com. So there's a tab at the top listed as Training Center. In that Training Center, you're going to find all things education, such as the training material, like the slide deck for today's call. It also gives you the information on any upcoming educational events that you might be interested, as well as our encore presentations that are up there for generally about 60 to 90 days. The encore presentations are a way you can review the recording of the live event without actually having to go into YouTube and view it from there. Jennifer did place a link in the chat to our live event page. So if you want the handout or the slide deck for today's event, you can download it from that page. And it'll be up through the end of today and maybe tomorrow morning, but it will probably be down by tomorrow. So if you want it, I do encourage you to grab it today. Finally, if you have any feedback about your experience today, there's opportunities now and at the end of this event to take our survey. So Jennifer placed a link to the survey in the chat, and she's also going to place it again there at the end of the presentation. So if you find you happen to need to leave this event early, you can go ahead and use that link that Jennifer put into the chat now. And otherwise, you know, again, you can use it at the end of the event, but we'll talk about other ways to take our survey. Finally, if you're listening to this event as an encore, so you're listening to the recording, we also encourage you to take the survey of the recording. The encore survey link should be at the top left or top right of your screen. There's going to be a little eye with a circle around it. But it's also available in the description of the event as well. On your screen now is our disclaimer that we have to show at all events. And our disclaimer basically says, the information I'm giving you is as true as the Medicare laws, rules, and regulations are on this day. But keep in mind, Medicare laws, rules, and regulations often change, and it's your responsibility as a provider to make sure you are following the most current laws, rules, and regulations that are in place on the date of service you are providing services to a Medicare beneficiary. So CMS website is your place to find the most current laws, rules, and regulations. On your screen now is a list of acronyms. Now, Medicare is full of acronyms, and so these are the most common ones that I have embedded in this presentation today, and I may or may not say out loud, but there's also other acronyms that I may just blurt out. If I happen to use one of those and use it unintentionally without defining it and you don't know what it means, just either refer back to this list if it's on the list, or put it in the chat and one of my associates will answer what that is for you. All right, why are we here today? My overall objective for today is that you learn about the Medicare review findings and what reviewers are actually looking for to strengthen your compliance with Medicare requirements for IVIG services. We're going to achieve this objective today by reviewing the coverage criteria and medical necessity. We're going to discuss the documentation requirements. We're going to review issues and trends that have already been identified in medical review, as well as discuss some practical tips to avoid these findings. So let's start by reviewing the coverage criteria. First, we're going to define immune globulins. So immune serums or immune globulins provide passive immunity to infectious diseases. The protection will be of rapid onset, but of short duration, so usually 1 to 3 months. Immune sera are obtained from pooled human plasma of either general population donors or hyperimmunized donors. It may be administered either by IV or IM, so intravenous into the vein, or IM, which is intramuscular, into the muscle. The focus of our medical review is mostly on immune globulins given via IV injection. They will also include tetanus, which is given IM. Later, we'll discuss the LCD and the local coverage article and the codes that are identified and the codes that our medical review department is looking at. So as per our LCD, which is L34771, and that's hyperlinked here in your slide deck in this very first bullet, immune globulins are available in broad spectrum form or disease-specific hyperimmune serums. So different types of gamma globulins are covered for specific indications that are listed in our local coverage determination. So for instance, gamma globulin IMIG is covered for things like hepatitis A exposure, measles, and rubella, to name a few. Specific hyperimmune serum globulins include several different disease-specific drugs. In this category are things like hepatitis B serum, which may be indicated for someone with post-exposure for transient prevention of hepatitis B infection. Also, rabies serum may be another indication under this category and used for post-exposure for the transient prevention of rabies infection when the patient has not been completely immunized with the vaccination. Under the specific hyperimmune serum globulin is also tetanus serum. So this may be indicated for transient protection against tetanus post-exposure to tetanus. I want you to keep in mind that certain immune globulins have specific criteria that must also be met. So for example, the LCD indications for tetanus serum state that the documentation in the progress notes have to identify a few things. And those things are like the wound is other than a clean minor wound, as well as the date of that wound or injury. It also says the active immunization with tetanus toxoid is unknown or uncertain, so you don't know when the last active immunization was. Or the patient has received either less than 2 prior doses of tetanus toxoid, or there has been 2 prior doses of tetanus toxoid, but there's been a delay of 24 hours or more between the time of the injury and the indication of the tetanus or the initiation of that tetanus prophylaxis. So again, these are just a few examples of coverage indications under that broad spectrum form or specific disease-specific hyperimmune serums. As the LCD moves on, it also lists coverage indications for IVIG, which is one of the main focuses of our actual medical reviews. IVIG provides immediate antibody levels So our LCD defines the different types, such as sandoglobulin, venoglobulin 1, or Privigen. It also lists the conditions that they're covered for. So there's actually 32 covered conditions that fall under the IVIG category, some of which are things like primary thrombocytopenia, Guillain-Barré syndrome, and that's where the IVIG is recommended as an equivalent alternative to plasma exchange in children and adults. Kawasaki's disease, and even desensitization for pre-kidney transplantation when certain indications are met for that patient. Remember, even though a patient may have one of the 32 covered conditions listed, your medical records must include the indications to support the use of IVIG. For those indications that you maybe are documenting stating routine use is not indicated, or where says routine use is not indicated, then your medical record must document the interventions that were unsuccessful or the reasons those weren't tolerated. So if you're going to go to it as a first-line use or as a use, you have to tell us what else in certain situations, you did try and wasn't tolerated or was not successful. And again, at a later time, we're going to go to the LCD and we're going to look at some of those. We'll talk about documentation in a little bit, but I do want to remind you that documentation must support objective response for continued coverage. So as part of your Medicare provider agreement, you also need to remember that medical records must be made available to the contractor upon review. So those are a few things that I want you to keep in mind. If we request documentation, you need to support that or supply that documentation to us. Or any of the federal review contractors request documentation, you need to supply that documentation to them for review. All right, we're going to switch gears in a little bit and talk about billing. But before we do that, I just want to jump out to the LCD so you can familiarize yourself where to find this information. So give me just a second as my computer is being slow today. And sometimes it's not just today, sometimes it's every day. Okay, so I provided in your slide deck that's going to take you straight out to this LCD on immune globulins. But what if you don't have the slide deck available, and what if you don't remember the number? If you just go to cms.gov, and this is their homepage, how do you find that Medicare coverage database? You can search for it, or you can just go to it with a couple of clicks. If you go to Medicare coverage database, and you're going to come to the search screen. If you know the number, remember that for some reason, you'll get to CD. If you don't remember it, which I went all the way back out. Give me just a second. I tend to not remember those specific numbers, but I do know it's for immune globulin. And so I'm going to do a search just by those keywords, and I'm going to look for WPS. You don't want to pull up any other provider's local coverage determination. If or any other contractors if we are your Medicare paying and processing contractor. So here, starting with L is the immune globulin, and you can tell this one is for WPS. So you can use the link provided there, and it's going to open that immune globulin LCD. When you're looking at any LCD, and this is just a little bit of information, this first line is sometimes closed. So to expand that, click on it, and you want to make sure, again, that you are following PS's local coverage determination. And you can see that right here. Yes, you are. All right, so as we scroll down, these are those coverage indications and limitations for medical necessity that we talked about in those first several slides. And we broke it down into the gamma globulins and the specific hyperimmune serums, as well as the IVIG information. And here are those 32 indications that we talked about. Now remember, there are some conditions that have additional documentation or additional conditions that must be met in order to use this. Again, like for myasthenia gravis, routine use is not indicated. So if you're going to go to IVIG here, you have to tell us about the other things that have been unsuccessful or are contraindicated, things that are used and tried or things that are contraindicated for your patient. So it's important that you look for the diagnoses in here, and then you look to see if there's any additional information needed before you administer the IVIG to the patient. In every local coverage determination, or I should say in most local coverage determinations, there is a link at the bottom to any local coverage article or LCAs or billing and coding articles. And you can see right here the A57554 is the billing and coding article for immune globulins that goes right along with this. And we'll talk a little bit about billing in the next couple of slides coming up. But, do pay attention because it has some documentation requirements. And then it's got all your coding information. Now, the LCA for this is pages and pages of codes. So I do encourage you to go through this and look at the different diagnosis codes and HCPCS CPT codes that are listed. So at this time, I'm going to jump back out to the slide deck, and we're going to continue on and shift gears for a bit and talk about billing and coding of these services. When medical review is performed on a claim, we not only have to look at the documentation to support that your coverage is reasonable and necessary, we must also see that you billed Medicare, what you billed to Medicare is actually supported in your documentation. So your bill and your documentation have to match. When it comes to billing and coding, the billing and coding indications, again, are found in that billing and coding article that we just looked at. So that article number is listed here, and that's that A57554. And again, you can link directly to this, but if you lose this slide deck or whatever, you can always just do a search on the MCD database for it. All right. So things that you're going to find in the article include those covered ICD-10 codes as well as those CPT and HCPCS codes that help to support medical necessity. The article also reminds you as the user that your documentation must include indications to support using IVIG and states that it must support objective response for continued use or continued coverage. So we got to see that it is benefiting your beneficiary in order to have continued use. When it comes to billing and coding, remember, when administering IVIG to patients over continuous days, providers should report each day's dosage on a separate line of coding using the appropriate date of service with the units reported in the not otherwise specified field in the claim form. So when separately identifiable evaluation and management services are provided and documented on that same day as the intravenous administration, they may be billed, but again, you'd have to use modifier 25 and again, refer to the local coverage article when you're billing these. If you have a separately identifiable evaluation and management service provided on the same day, the one thing I do encourage you to do is take all the information about the IVIG out of the documentation and then relook at your documentation and make sure that what's left is enough to support that evaluation and management code on its own. If it is, you can use that and append a modifier 25. You can't double dip information. So if that documentation exists as coverage to support the IVIG, that information cannot be used to support the coverage of the E&M, as well. It has to be each of those codes have to stand on its own. We get that question a lot, so I just wanted to give that little reminder. All right. Remember, as we pointed out in the local coverage article, immune globulins must be supported by a covered diagnosis as well. So if you remember, there's pages and pages of those covered diagnoses in that LCA. I only scrolled through a few of them, but there's pages and pages. So if a diagnosis is one that is not one of those listed in the article, the service will be denied as not reasonable and necessary. And as providers, you're going to be liable for those services if an ABN was not issued. And we're going to talk in a little bit about the ABN by itself, and that'll come up in the next couple slides. All right, let's talk about why we're doing medical review and what our goal is. The overall goal with any medical review is to prevent improper payments and protect the Medicare Trust Fund. So this is in an effort to reduce the risk in total dollars at risk, as well as total dollars at risk per claim. So when we do these reviews, we're using the LCD as our guide for these reviews. During this review, what are we looking at? Why are we looking at? We're looking at these specific HCPCS codes that are listed here on the screen. They're also defined in the LCA, but I'll give you a little rundown of what those are. Again, some are IVIG, some are IM, such as the tetanus. The specific codes, again, are also defined in the LCA. So the J1573 is that injection hepatitis B immune globulin. The J1575 is the injection immunoglobulin hyaluronidase. I know I'm going to botch some of these words, but that's okay. The J1599 is the injection of the immune globulin intravenous non-lymphocyzed, not otherwise specified. The J1670, that's the injection of the tetanus immune globulin. So that one's the IM one. And then again, there's the J1561, 66, 68, and a J1569. And those are all listed here. Again, the full definition of those is in the local coverage article. So the important part is we chose these specific codes because our data analysis showed that the use of these specific codes represented a significant risk in total dollars. So the total dollars at risk was greater than in the 99th percentile. So the total dollars at risk per claim was greater than 75 percentile. So when we run data analysis to determine if we need to do a targeted probe and educate review, we're looking at not only what types of claims pose the greatest risk for error that are billed specifically to us as the MAC, but then which providers in our MAC jurisdictions pose the highest risk of potentially submitting claims for this service that might not be medically reasonable and necessary. In this particular case, the data analysis for these HCPCS codes showed that we have some J5 providers that met the criteria for posing potential risk for reporting these codes improperly. So right now, the reviews have started in J5. That doesn't mean if data continues to show at-risk providers in our J8 that we won't go after providers in J8. We just started it in J5 for now. Now, generally with medical review, we don't know until we actually review claims if the providers are, truly outliers and truly doing providing services that aren't medically necessary. So we don't know what the potential errors may be. In this case, we've got enough data for me to bring you some of those potential errors, which we are going to talk about in a little bit. Now we're going to shift gears again just a bit and talk about how and why we need to support all the coverage indications and billing in our documentation. Remember that old mantra, if it's not documented, it's not done. Listed here are the documentation requirements that are also listed in our LCD, but let's go over these. So per our local coverage determination, the things listed must be included in the documentation, and that needs to include indications to support the use of IVIG. So what's the diagnosis? It's the why it's needed. So in air quotes, why it's needed. That's what you're supporting. Those indications cannot be for routine use. The medical record must also show the interventions for that particular diagnosis that were unsuccessful or the reason they were not tolerated if that's indicated. For example, under the IVIG, the alloimmune thrombocytopenia refractoriness to platelet infusions. So routine use for that is not indicated. IVIG may have a role in patients with severe thrombocytopenia of documented immune basis for whom other modalities are unsuccessful or contraindicated. So make sure, again, in your documentation, you are following those additional words. See an objective response for continued coverage. In other words, is it working? So your documentation must show a measurable response to the treatment when that's indicated. Next, we need to know what the immune globulin was used for. This will help support that you're using the right drug for the right reason. So, and we'll talk about the medication administration record or the MAR information in a little bit as well. Also, what other documentation do you have to support the use of the immune globulin? If there are other pieces of documentation to support the proper use for the proper reason, the correct dose, correct route, etc., then you need to include that in your documentation, whether we ask for it or not. If you feel it supports why you are providing this service to this beneficiary on this day, include it in your documentation request. All right, additional documentation requirements. So these are some specific components of documentation that will need to be included to support those indications that we spoke about on the last slide. Most of this really helps support all of those questions that we had at the end of the last slide. Is this the right drug, the right dose, the right administration, right use, et cetera? So the things that we look for to support those are your physician history and physical. Office or progress notes. So these really help to support, you know, the information in the HMP, the need for the IVIG, the results, et cetera. Any test results to get to the diagnosis or any tests needed to determine the diagnoses, as well as any pre or post administration labs, if those were necessary to check things like antibody levels. We need to see accurate weight in kilograms, and this is really important because the dosing of some immune globulins are based on the actual weight in kilograms. Information like history of recent and severe infections that may warrant the need for immune globulins. So this may be info we find in the progress notes as well. But this is a reason, you know, helps support the reason for administering the immune globulins. And if it does that, make sure that documentation is provided to us as well. Goals. What are your treatment goals? What's your plan in this case by administering this IVIG? Is it to cure? Is it to stabilize? Is it to treat? Is it to prevent? Those are things that we should be seeing contained within your documentation. Finally, infusion or injection record. So usually this is your Medicare administration record or your MAR. If it is given IV, we need to see start and stop times or total infusion time. If given IM, we need to, you know, see things to verify the correct route is documented. That's why it's important to send the medication administration or infusion, injection, or MAR, whatever you may call it, so we can verify all those things we just discussed. The final piece of documentation you should keep on file and submit if we ask for it in review is an ABN. So let's just briefly talk about that ABN. ABN should be issued to beneficiaries in situations where Medicare payment is expected to be denied. So if you have reason to believe that for this patient, in this situation, on this day, for this diagnosis, et cetera, that Medicare will most likely not pay for the service, and you want to provide the service, by doing this, by issuing the ABN, then you are getting the patient to agree that if Medicare does not pay, they will pay for the service. So if those things exist, then you should issue the ABN to transfer potential liability to your patient. As a provider, you must follow the fee-for-service ABN instructions. And you can get right to those instructions from this link that I have provided on this slide. All right, now we've told you about why we are doing the reviews, why they came up in our data, what documentation you need to have to support the services as billed. So let's now talk about what we're finding upon review that could cause an unfavorable decision. So the first one is pretty straightforward. It's lack of valid physician order for the service. So it's pretty simply, your documentation must contain a legible, signed, and dated practitioner order for the infusions given. So lack of physician or MPP order could and will cause denial of your services. The next finding is lack of covered diagnosis or condition. Now, keeping the LCD in mind and the covered conditions and indications that we went over, remember for IVIG, there are 32 conditions listed where IVIG may be indicated for. Our records are going to focus on those the diagnoses or conditions to support the coverage of the services. So again, going back to the HCPCS codes that we talked about that we're going to review, make sure you're going back, looking at those covered indications, looking at those diagnoses and CPT codes in the local coverage article, and making sure you have those conditions that are necessary. If not, if it's lacking a covered diagnosis or condition, we probably will deny upon review. Next comes lack of tried and failed treatments. So this applies to certain diagnoses, not all. For instance, with myasthenia gravis, routine use is not indicated. IVIG may be considered in patients with myasthenia gravis to treat acute severe decompensation when other treatments have been unsuccessful or are contraindicated for that patient. So that's why it's important to refer to the LCD and list those conditions of coverage that are outlined within it. So if it says you have to try something first before the IVIG, we are going to expect that your documentation contains that information. If it doesn't contain that information, your service will probably be denied. Next up is the lack of a valid medication administration record. We need to see what medication was administered, what route, the start-stop time or total infusion time if it was given as an infusion. We need to see how much was administered and that administration was also signed and dated by the person who administered it. So remember the 5 patient rights of medication administration when documenting in your MAR. You have to have the right patient, the right medication, right dose, right route, right time. And then finally, let's end with some practical tips that could save you if you ever have your immune globulin claim reviewed. If you are a practice or facility that administers immune globulins, you should ensure your documentation is legible and complete. You need to ensure that it meets the coverage criteria listed in that LCD and it meets the billing and coding criteria listed in that local coverage article. That it supports the type of serum that you administered. It supports that tried and failed treatments were provided first when those are required. You need to ensure your documentation is not missing any of those required components that we talked about. Ensure that it's also submitted within the required time frame. Remember, if we pull for medical review, you have 45 days to submit that documentation to us. And that it also contains the legible signatures and dates. So next on your screen is just some resources where you can find additional information for IVIG services. And so I just made those resources available on this link or on this page. So let's recap before we get to questions. Today, about what our reviewers are looking for and how to strengthen compliance with Medicare requirements. And we accomplished today by going over an overview of that coverage criteria and medical necessity that's listed in our LCD, because remember, we're using that LCD as our review guide. We discussed documentation requirements And know that if you are ever selected for medical review of these services, that your ADR is also going to contain a list of the documentation requirements we want you to submit as well. We also reviewed those issues and trends that have already been identified in our medical reviews. And then finally, we went over some practical tips that'll help you avoid findings if you are selected for a review or if you are currently part of that targeted probe and educate process. So at this time, I know we're getting close to call end time. I'm going to look over and I see there's a question that came in that says, if the provider orders one brand of IVIG, but the pharmacy substitutes for biosimilar, will that result in a denial? It should not if just the brand is different. You will need to verify that, you know, if it falls under the same CPT HCPCS code as the one that was originally ordered. If you believe it is different altogether, you should seek out a new order from the physician or a verification order that says it's okay to substitute, you know, one for the other if it was unavailable. And make sure then that your billing of the service is accurate for whatever was administered. Okay, and that is the only question I see in the chat right now. So I, in the interest of time, am going to proceed on, and I'll look over briefly before we conclude to see if any additional questions come in. So coming soon to your email address. When this webinar is complete, you're going to get an email. If you only called in or you logged in via a mobile device, you may not get this email. This email is your proof of attendance and has contact hours in it if you need to submit those to your accrediting body for continuing education. So don't delete that without reading this. If you don't receive the email, but you did log in, just send an email to us at that email address that was provided at the beginning of the event, and it is coming up on the next slide, and it's wps.gha.education@wpsic.com, and let us know that you called in and what phone number, and I'll send you out a certificate to your email. Follow-up questions. If you think of any questions regarding this event that you think of, you know, after we've concluded the day, go ahead and email those to us at that same email address. Jennifer also put it in the chat in case you wanted to copy and paste it. But if you have the slide deck, if you click on that, it's going to populate an email for you. And just send us that follow-up question within the next 7 days. Don't send us anything that's claim specific. Those questions need to go to customer service. We do not have access to those billing systems to look up billing information. So again, those claims have to go to customer service. But anything that pertains to this education or coverage criteria, you can send those to me within the next 7 business days. All right, as I stated at the start of this presentation, we value your opinion. We want to hear from you on how we did on this event. So this survey only takes a few minutes to complete, and that's why we want to give you the opportunity to take it now while you're still in the webinar. It's your opportunity to also tell us what additional education you would like in the future, because many of our educational events that we provide are a direct result of those requests that come through. So Jennifer did place that in your in the chat again for you, but you have a few different options. When the event closes, a page is going to come up that looks like this. It's going to tell you it's taking you to an external site. It's going to have a destination site in the bottom that's going to say something with CMS and Qualtrics in it, and that is just WebEx's way of saying hey, we're taking you to Medicare survey. It's not spam, it's just another way to get to the survey. And there's also a link that will be provided in that email if you would rather use it that way. All right, and then finally, we want to hear from you. We're committed to making these changes to improve your educational experience. So some of the most recent changes we've made based on those survey comments are we've now added chapters to our YouTube videos. So the encores and any YouTube, just general education we provide, there's chapters in the description. And you can actually click on just the part that you want to re-listen to. So you can click through, you know, and skip different parts if there's just one thing you wanted to go back and listen to. We've also included training indicators in our descriptions of our event. So now you know if this event is clinical in nature, if it is billing, if it is UBO 4 or 1500, et cetera. So pay attention to those training indicators, and the training indicator information is also listed on our website under our training tab. And finally, on behalf of Jennifer and myself, as well as our medical review department, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.